Good morning, ladies and gentlemen. I guess we have to start. It's 3 minutes on the hour. I'd like to welcome all of you to the October lecture series of AI for PEP. And my name is Emmanuel Musa. I am the network manager. First, I'd like to speak very briefly about AI for PEP network. So, AI for PEP network is a global network of AI experts, research professionals, and practitioners from across the global south who are really committed to driving AI-powered innovations in global health. And our mission is to leverage Southern-led responsible AI solutions to strengthen equitable healthcare systems and support research activities through community-driven initiatives. So we have hubs in over 23 countries at the moment, all across the global south. So we have hubs in the African region, we have hubs in the Latin America and Caribbean region, we have hubs in the Asian region, and we have hubs in the Middle East and North African region. And in all of these regions, we work closely with various actors, including governments, including various public health agencies, as well as civil society. And we do this in order to collaborate through this network and conduct inclusive research that support AI-powered healthcare innovations at all levels, be it subnational, national, regional, and of course, at the global level. So our work is really grounded in the principles of decolonizing research and ensuring ethical AI governance and supporting gender equality and inclusion. So I welcome you once again to today's lecture series. And today we have two distinguished experts who will be speaking to us. First, we have Dr. Manuel Colomé. Dr. Manuel Colomé is an associate professor and director of the Health Research Institute at the Autonomous University of Santo Domingo in Dominican Republic. He is the project lead of the AI4PEP project in the Dominican Republic, working on artificial intelligence and eco-epidemiology-based early warning systems for the improvement of public health response to Aedes-borne viruses and other vector-borne diseases in the Dominican Republic. He is a physician epidemiologist and an expert in infection prevention and control, and the head of the epidemiology unit or department at the Dr. Hugo Mendoza Pediatric Hospital. His research interests include pediatrics, infectious diseases, and strengthening health systems and the social determinants of health. So I'd like to welcome first Professor Colomé. Professor Colomé.
Yes, thank you.
Okay, so we have Professor Colomé there. Professor Colomé, I will also introduce our second speaker, but I'm going to do that again. Our second speaker is Professor Blessing Ogbuokiri. Professor Ogbuokiri is an assistant professor of computer science at the Brock University in Canada, and he's the director of the Responsible and Applied Machine Learning Laboratory in the same university. Dr. Ogbuokiri specializes in artificial intelligence, machine learning, and data science and ethics, with over 15 years of experience working in diverse settings, academia, government, and in practice. He collaborates with groups like the Africa-Canada Artificial Intelligence and Data Innovation Consortium, academic, many other research organizations in Canada and the Global South and in many parts of the world, actually. And he has been involved in applying AI in managing infectious disease outbreaks like COVID-19, malaria, monkeypox across the world and in the Global South, particularly. So we welcome you today, Professor Blessing. And Professor Blessing will be speaking to us right after Professor Colomé. So once again, I welcome all of you. to this very important lecture today. And I'll now pass it over to Professor Colomé, who will be talking about AI for epidemic preparedness or readiness, lessons from the Dominican Republic. Over to you, Professor Colomé.
Thank you. Good morning, everyone. Thank you for joining us in this conference. Can you see my screen? Can you see my screen, Professor Musa? Yes.
Yes,
Okay,
I can see your
great.
screen.
Thank you. So today I'm going to talk about artificial intelligence for epidemic-related lesson from the Dominican Republic. So uh, I'm this conference is based in a research paper that we published in Transaction Tropical Medicine from the Royal London School of Tropical Medicine Society. So I invite you to join us and try to read this paper when we discuss deeply what we are doing in our country. Um, so the context, let's talk a little bit about the challenge in Dominican Republic. We have the international health regulation from WHO. So basically in 2019, the Pan American Health Organization deployed this evaluation in Dominican Republic. So they identified some gaps in weakness, so in surveillance, workforce development, and intersectoral coordination. So in response to that, uh, let me tell you something that the research can ignore the social problems. So what we did, we joined from the Universidad Autónoma de Santo Domingo to the I4PEP initiative. Uh, so Dominican Republic is a hub in this artificial intelligence for pandemic and epidemic preparedness and response network. So the network have almost between 16 and or 18 nodes, hubs in all the world, in all the global south. So we have the pleasure to be part of this initiative. And this initiative is totally and funded by the IDRC and United Kingdom International Development. We participate in the project for the Universidad Autónoma de Santo Domingo in response to this local problem with the Health Institute research. So we develop a team, prepare a proposal to address the problem. So we pick one of the worst disease that the country have is dengue. So the health in Dominican Republic is working in that disease, the dengue are other arboviral disease like chikungunya or Zika. So we have this methodological approach. First, we prepare a multidisciplinary and technical team. Our team have members from economic science, health science, and public health, also math, applied math, and computational science. So second, we analyze we made a situation analysis, try to prioritize the setting exercise, and three, we developed the training models with pilot tools and community engagement plans. So we developed a model based on ecoepidemiology, trying to address the dengue outbreaks in Dominican Republic. Phase 4, we have interactive feedback through mechanisms for workshop and field validation. And our methodological approach have the qualitative implementation science, and we have the validation with multi-institutional consultants, including a strong collaboration between the government, the stakeholders, as the community and academia. So then we have our project have 4 lines of actions. First is capacity building, that because we want to address the gaps identified in the WHO report. So we have a national health fellowships when we train professionals in health science, in public health, in ethics. All the composition of this project is multidisciplinary. So not only doctors or nurses, we have people from the social science, for example, anthropologists, and we develop strong collaboration with other university like University of South Florida. Um, we developed this predictive surveillance tool. Also, we collaborate with other countries and um, other dengue researchers that they are working on machine learning models for early detection of airborne transmitted disease. And we have the strong collaboration and ethical governance because we sign agreement with strategic partners of the government, academia, or civil society. We we create a claim of equity and inclusion because we invite the community to join the project to develop this artificial intelligence solution with them. This is important because in some cases, a researcher only developed the research inside the office and they didn't more of the time take include the community or the stakeholders. So let me show you some part of the resource and the impact of the project. So the first one is the training. We have the institutional integration because because part of the team participate in the technical review committee for the World Health Strategy of the Ministry of Public Health. We have the policy revision because we have invited to be part of this national training on ethical guidance on digital surveillance. The model is replicable because we have adaptable framework to other laws and middle-income countries, and also because the disease that we choose, the arboviral disease, is very common in tropical and subtropical countries. It's aligned to the international health regulation because we include this real-time surveillance and equitable access to emergency and preparedness technology. And finally, we have the ethical because we have a potential of responsible use of artificial intelligence. So in 2023, we have almost 30,000 cases of dengue at national level. So we have most severe cases, and that's most of the cases, 10% of the cases of the country occurs in the Hospital Hugo Mendoza. So Hospital Hugo Mendoza has in the middle of the outbreak of the country. So we developed this tool and we share with the hospital, and they with the aim of to improve the health emergency response to this outbreak. So with the system have some functionalities. We have the anomaly detection, identify nonlinear patterns preceding outbreaks. We have weekly forecast, predictions day for weeks in advance, and we have the health partial heat maps on early alerts. So we combine some climate data, some economical and social determinants of health data, and of course, clinical and epidemiological data. For example, we include data about the weather, the heat, the temperature, rainfall, humidity, and we include data about the case definitions of dengue, severe, confirmed, probably, etc. We use the data to create this predictive model. But about the lessons, with this information, the hospital can prepare for the outbreak. So I'm doctor in the hospital also, I'm a doctor here. So we made a meeting, we have a meeting with the director, and we use this tool to understand how we can improve our response. For example, with that tool, we can give advice to the director, and she, for example, can include more doctors in our medical team, or she can buy more medicines or more medical supplies. So this is very important because you have a strong idea about what you can do, what you have to expect. Okay. Lesson learned, some recommendation. We have the compressing human capacity. So we have to integrate ethical, technical, and social competence for sustainable impact. We have the participatory design. Artificial intelligence on public health must be context sensitive and grounded in community realities. And third, locally relevant data, early warning system informed by contextual data and multi-sectoral collaboration. Four, global soul leadership. Low and middle income countries can lead responsible artificial intelligence innovation, and institutional trust, transparency, and engagement essential for legitimacy and effectiveness of artificial intelligence tools. So my key conclusions are that artificial intelligence can accelerate the international health regulation implementation from WHO. So in resource-constrained setting, focus on local relevance and ethical principles and equity builds technical and social capacity. And so collaboration and regional innovation are very fundamental. So my recommendation is that broader adoption of artificial intelligence engage frameworks in the global south, ensuring collaborate governance and public health prepared. So thank you.
Thank you so much, Professor Colomé, for that very detailed and quite concise presentation. Um, I have a quick question for you before we open the floor for others who may have questions to ask. Please, if you have a question, you can unmute yourself and ask. Alternatively, you can drop your question in the chat and we will see it and answer the question. I'd like you to share with us some of the challenges you encountered in trying to access climate data, for the work that you did.
Yeah. One of the most problem using this working this project is the access to data. So this is curious because when I ask for the data in my country, I am still waiting for that because because they have a fragmented data system. So the National Meteorology Center, they generate some data, but also the Ministry of Environment. But what we do? So we contact to the NASA from the United States, and they have some satellites. So we we request access to data from Dominican Republic, and NASA give us the data. So we use that data from NASA. Regarding to the data from Dominican Republic, basic uh, social determinant of health. So we download the data from the World Bank. Data from epidemiology. So we requested data from the Ministry of Public Health, and they gave up. But I think that the best way to do that is with open data. All the data used with public funds must be released. Okay, and that's happening. That's is not happening in all my country. The data is very restrictive, so we have access for a regulation, but uh, I think that everyone that work with public funds should be released the data because it is with my money, you know. So I think that it's a challenge to do that. But once you beat that challenge, everything will be more easy.
I fully agree with you. When you work together in a collaborative manner using the One Health approach, where you bring all the stakeholders to the table, then issues of access to data will also be addressed. So thank you so much. Are there any questions for, if you have a question for Professor Colomé, you can raise your hand. You can indicate by raise of your hand, or you can drop your question in the chat. There's a question for you, Professor Colomé. How transferable are your results, for example, to Asia, or are they area specific to Dominican Republic alone?
Okay. I think that it depends about the setting. Mm, mm, some variables that we use are free to the World Bank, but the Dominican data has some limitations. So uh, the climate radar about for NASA, they only have data from 9 provinces of the country. What the means of that? That the 9 countries correspond to the 9 airports that we have. So the data is getting from the airport. So this is why our model have that limitation, but we use this data only in the Dominica in the Santo Domingo province. So we choose one to 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 uh implement this solution. But I think that the solution is replicable and scalable to other countries with similar contexts. Another limitation that that can probably could affect the model is that some data from economy, for example, helping income, for example, that information is maybe is not up to date in some cases, you know. But I think that the solution could be transferred to other countries that have the same problem. Because, but I think that is very transparent. So we want to make this publication, and we expect to share the results as soon as possible to other researchers to try to to do the same. And we are open to make some collaboration to other countries and try to help and share what we are doing here.
Wonderful. So there's room for collaboration with other countries.
Yeah.
This is really great. Are there any questions? I don't see any hands. But Professor Colome will still be with us for a while, just in
Yeah.
case you remember a question, you can ask. So I will also leave Professor Colome's bio in the chat. You can also reach out to him if you like. So we are going to move on very quickly to our next speaker. And I introduced him at the beginning, but for the sake of those who have just joined us, I'm going to reintroduce him. Uh, so Professor Blessing Ogbuokiri is our next speaker, and he's an assistant professor of computer science at the Brock University in Canada, and the director of the Responsible and Applied Machine Learning Laboratory in the same university. He specializes in AI, machine learning, data science, and ethics, with over 15 years of experience in academia, uh, uh, practice, as well as industry and research, of course. He collaborates with diverse groups of researchers like the Africa Canada Artificial Intelligence and Data Innovation Consortium, ACADIC, the Black in AI Group, the Canadian Black Scientists Network, and several community health centers in Canada and across the global south. His areas of interest include applying AI in managing infectious diseases and all other aspects of global health. He's been involved in managing COVID-19, monkeypox, and many other key outbreaks in the global south. So I'd like to welcome Professor Ogbuokiri, and he's going to be speaking with us on the next topic, which is about uh, AI fairness in healthcare application.
Okay.
Dr. Ogbuokiri, over to you.
All right. Thank you very much, Dr. Emmanuel. Thank you for having me. Okay. I just want to be sure. Can you all see my screen?
Yes, we can see your screen.
All right. Interesting. Thank you very much. And welcome, everyone. Hi, everyone. I will say thank you for joining this presentation on AI fairness in healthcare applications. The goal of this talk today is to explore how fairness principles can be effectively applied in healthcare AI, and moving from simply identifying bias to actually developing mitigation strategies, and these mitigation strategies actually promote equity and trust. Of course, how given the way the speaker just introduced me, my name is Blessing. I'm from Brock University, and I lead the Responsible and Applied Machine Learning Laboratory in the same university. So our lab, focuses on developing interpretable and machine learning, interpretable and fairness-aware AI systems with strong emphasis on practical solutions and practical solutions that can be used for healthcare and other socially impactful domains. So, as the subtle title that I put here as you can see, the subtle title is actually one of the things that we are going to be working through, both the diagnostic side of fairness and how we can detect bias, and also try to understand the intervention side, how we can fix it. So I also try to put this image, which on the side, which I see as like what symbolizes that intersection between medicine and technology, which also serves as a reminder that fairness in healthcare AI isn't just a technical issue. It is about ensuring that intelligent systems serve all patients equitably, regardless of background or data representation. And that is what we talk about when we are, talking about AI fairness in healthcare. And that will take me to the next thing, which is one of the motivation for this talk. We're looking at why is fairness in healthcare such an important topic at this time? Why are we so interested in talking about fairness in healthcare? Firstly, it's about patient safety. Because when we talk about AI and we're trying to apply it in healthcare, then patient safety is at stake. When AI systems used in diagnosis or treatment are biased, say maybe when you train a data that is underrepresented with a certain group, they can produce inaccurate results or even harmful recommendations. For instance, a misdiagnosis of or rather a misdiagnosis due to biased data can delay critical treatment for a patient, and that is a problem. So patient safety, becomes something that we all need to be careful with. And the second thing is the issue of trust. Trust is actually fundamental in healthcare, because if people understand what you are doing with your AI tool, how it was developed, and what result they are going to get, if you understand all those processes, then that can actually improve trust. If a patient or clinician perceives AI system as unfair or unreliable, adoption will stall. Like they wouldn't be able to accept to use it. So fairness directly contributes to public confidence and the willingness of healthcare professionals to integrate these tools into practice. And the third thing is regulatory compliance. Regulatory compliance is also becoming increasingly important. How so? Because laws and standards like the EU Act and the FDA guidelines, they now emphasize on transparency, accountability, bias audit, and ensuring fairness. Like letting to know that ensuring fairness isn't just like ethical, but it's also a regulatory necessity. When we talk about transparency in AI systems, we mean that users or developers should make the process of developing these tools transparent. That is to say, we should know how the models came about, the decision he made. People or clinicians or stakeholders should be able to know, okay, this is why this model made this decision, and these are the key variables or features that influenced the decision that the model made. And the issue of accountability comes in when stakeholders begin to ask who is to be held responsible when these AI tools make a decision, whether good or bad. Who is supposed to be held responsible? And the bias audit is, of course, that's part of the things we are talking right now, which is to say that there should be a routine check of the system, of the AI system all the time to be sure that it does what it says it will do and it does not favor any particular class or domain at any time. So to illustrate, consider real-world examples. So one is, a skin cancer detection model that performs poorly on dark skin tones because it was trained on lighter skin images. So when you train a model with a large chunk of lighter skin people, and now you want to do a classification with darker people, then the model definitely is going to perform poorly. So another example is radiology models that showed reduced accuracy for female patients or underrepresented ethnic groups due to skewed training data set. And that is where bias comes in. When the data is completely skewed to a particular class, then the model will definitely will be biased against the underrepresented class. And these cases remind us that fairness isn't just optional, it is essential to ensuring AI benefits everyone equally, not just those who resemble or who resemble the majority of the training data. It is the benefit should be for all in general. Okay, so talking about the foundation of fairness in AI, let's look at some of the key matrices. Let's understand why this fairness matters, and let's also look at this foundation, how we can measure and address fairness in AI systems. There are several key features that we can, several key fairness matrices that we can use or that can be used to measure or to evaluate a model for fairness. And number one is the demographic parity. The demographic parity actually checks whether outcomes are evenly distributed across groups. For example, if an AI model predicts disease risk, demographic parity asks, are positive predictions equally likely for all groups, regardless of their race or gender? That's what demographic parity does. Make sure that there is that spread across all the classes. The equal opportunity is a second fairness matrix. And equal opportunity focuses on the true positive rate. It asks a question that whether the model is equally good at identifying actual positive cases for different demographic groups. And this is particularly important in healthcare, where missing a diagnosis for one group can have a severe consequence. and equal opportunity comes to play in that sense. Another one is the disparate impact, and this also measures whether a decision is disproportionately or decision disproportionately affects one group compared to another, and it comes common. It's more like a common matrix that is used in legal and ethical evaluation of algorithmic systems. Then we also look at the differences between what we call fairness auditing and fairness interventions, because these are very key points of or key foundation of fairness in AI systems. So fairness auditing actually involves evaluating a model to detect and quantify bias, essentially diagnosing the fairness problems. We use fairness auditing to also, routinely check if the model produces what the right result, and if it favors everyone, right? If it favors all, regardless of that person's gender, race, or whatever. Another one is fairness intervention. The fairness intervention, on the other hand, means like acting to correct it or correct the bias, as the case may be. This could be involved in, or this could involve rebalancing the data set, which is like some of the mitigation strategy that could be used to address the issue of bias in AI model for healthcare. Another one could be adjusting models with excuse me, adjusting models with or applying fairness constraints during training. So in summary, what auditing tells us where bias exists, while intervention focuses on how to fix it. So both are very critical, because that auditing will help you to find where the bias is, and intervention, of course, fixes it. And they are very critical in building a trustworthy healthcare AI systems. Okay, so I just quickly went into some of the case studies and some of the works that we have done. The first case study here is from our project titled Cross-Domain Fairness Audit of Sentiment Label Bias in Foundation Models. So in this work, we try to evaluate how major foundation models, when I mean foundation models, I mean like your OpenAI, ChatGPTs, Gemini, DeepSeek, and Llama, how they perform when compared to human-labeled sentiment across multiple test domains, such as your tweets, reviews, and sarcasm-labeled samples. So the goal was to audit fairness and reliability across contexts where language can vary dramatically, and from formal reviews to informal or sarcastic tweets. We try to apply fairness metrics such as demographic parity, equality, equal opportunity difference, and disparate impact ratio to quantify disparity between groups and dictate labeling inconsistencies. So our findings in this research revealed that while these models often align with human labels on straightforward tests, they also showed some clear systematic bias and performed and the kind of performance drop in informal sarcastic tests. So they had issue with the sarcastic or sarcasm or sarcastic contest. So sarcasm is particularly, or sarcasm in particular proved challenging as models tend to misclassify sentiments, or the sentiment polarity due to literal interpretations and all that. To mitigate this, we also tried to implement a pilot sarcasm-aware multi-task fine-tuning approach. And what we did was to train the model to jointly predict sentiment and sarcasm. Then this actually significantly reduced the misclassification that was done, or misclassification disparities, and improved fairness metrics across sarcasm samples. Overall, the study actually highlighted the importance of fairness audit for foundation models, and also shows that lightweight mitigation strategies can effectively improve fairness without extensive retraining. So when we did that, we also look at our case study in having to have it to healthcare connection. What's the connection with this kind of research in the healthcare space? So we connect our fairness audit findings back to the healthcare context. We found that patient's note, having a patient's note of this nature that or clinical feedbacks that doctors write, often can resemble informal text, such as tweets or online reviews. Okay, so they include shorthand, emotional expressions, and even sarcasm or frustrations, all of which can confuse sentiment or risk morals if not handled carefully. So the pilot sarcastic or sarcasm aware fine-tuning we developed earlier can actually, learn from, can actually be trained or learn and dictate both sarcasm and sentiment simultaneously. So this can actually prove useful beyond social media. And this same approach can help make healthcare NLP systems, they can help them make them fairer and more reliable, particularly when interpreting patients' reports, data, or clinicians' notes. The key takeaway here is that the bias mitigation techniques from social media tests can actually, effectively be generalized to healthcare domains based on what we did. And where subtle linguistic cues and emotional tones play a crucial role in accurate and equitable AI predictions. So to say that we can use this approach to interpret the clinical notes that the doctors write and use it to make predictions in that case. For instance, this sample clinical note could be predicted to be pneumonia based on the things that the doctors have written. Okay, so we also did a second case study that I want to use here is another project that we did titled the Geometric of Bias in Contractive Embeddings, a Spectral Analysis. Okay, here we try to explore how bias can be dictated directly from the geometry of learned embeddings. That is from the structure of the feature space itself without relying on the full label supervision. So the core idea is to construct a similarity graph from embedding representations. And then we apply spectral clustering to analyze how the data naturally groups itself. So by studying the eigenvectors of these graphs, we can now detect hidden subgroup disparities. We also look at patterns that suggest representation bias, and even when sensitive attributes like gender or ethnicity are unavailable, we can actually be able to do some bias detection in this case. So we tested this approach on two benchmark data sets. One was the Celeb A dataset. Celeb A dataset is a dataset which includes facial images with demographic variations. And we use the ChestPath dataset. The ChestPath dataset is a large medical X-ray dataset that is commonly used in clinical AI research. Our method also achieved a competitive accuracy while significantly reducing fairness gaps compared to both supervised and heuristic baselines that already exist. And the key takeaway here is that spectral method that we designed can uncover and mitigate bias geometrically, making them valuable for responsible AI, especially when labels or demographic metadata are not there or are limited. Then, comparing this to healthcare, or rather linking it to linking our geometric bias analysis back to the healthcare domain, we can say that in medical imaging, one of the biggest challenge for fairer or fairness research is that demographic labels are often unavailable or incomplete. And many datasets, such as the ChessPart or the Mimic CSR dataset, contain thousands of X-ray images, but they also lack detailed patient's demographic information. So our spectral approach actually provides a way to perform fairness check without relying on these labels. And how do we do that? We do that by analyzing the structure of the embedding space and looking at how the images cluster or separate. We can dictate the potential subgroup disparities even when we don't explicitly know which image belong to which demographic subgroup. The experiment also showed a competitive accuracy and a significant reduction in fairness gap, which is one of the things we are looking at, how we can mitigate the bias. And that also proved that this label-free kind of method can also produce equitable representation when you are building a model. So the main takeaway here is that the label-free fairness evaluation is both scalable and interpretable, which makes it a practical tool for responsible AI in healthcare imaging systems. And this is because this healthcare imaging systems is where privacy concerns or missing labels can make traditional fairness auditing difficult. And that is what we did. Then looking at our third case study here, which is one of our projects again in evaluating fairness in contractive embeddings using proxy demographic indicators. And here, we try to discuss a common challenge in fairness research and what happens when explicit demographic labels are missing. This is often the case in large data sets, especially in healthcare, where privacy regulations can limit access to sensitive attributes like race or gender, because a lot of people do not want to reveal their medical information. So to overcome, to overcome this, we used proxy demographic indicators such as the age bins or hospital region codes as a substitute for direct sensitive labels. And these proxies allowed us to uncover latent subgroup level disparities that would otherwise remain hidden in a contractive embedding space. We evaluated this method, using two benchmark data sets, the CELEB-A data set, which contains facial images, like I said earlier, and the ChessPart data set, which is a large collection of medical X-ray images. So our analysis also revealed that the CELEB-A embedding showed strong demographic dominance, within clusters, indicating bias even when accuracy metrics appeared high. In contrast, the ChessPart embeddings were more balanced, and that was suggesting to us that the modularity of data, visual, like your visual facial data versus medical radiographic data, plays a significant role in how bias manifests. And the key takeaway here is that the proxy-based fairness auditing that we created can effectively dictate hidden biases without needing sensitive demographic labels. And that also can, make it a powerful and lightweight tool for responsible AI evaluation in both social and healthcare domains. And to look at it to connect it to the healthcare sector, to connect this to healthcare applications, in most healthcare settings, sensitive demographic data such as race, gender, identity, or ethnicity is often missing or intentionally excluded from the data set due to privacy and ethical concerns. Because I said earlier, a lot of people do not want their data shared, especially their medical data in that sense. So this makes traditional fairness auditing extremely difficult since the model's performance across domains, across demographic groups, can't be directly measured without these features in your data set. So to address this, we propose the use of proxy indicators such as your zip codes, hospital regions, or age groups as indirect demographic signals in the data set. And these proxies can serve as a practical tool for fairness assessment, and that can also help us to dictate whether certain groups of patients, perhaps from specific regions or age ranges, are systematically disadvantaged by an AI model's prediction. So our findings show that these proxy-based audits are lightweight yet informative, enabling bias dictation even in real-world electronic health record systems where demographic attributes are limited. I mean, I just used this sample electronic health record. So the takeaway here is that proxy indicators provides a practical and scalable solution for fairness auditing in healthcare AI that can allow responsible monitoring without compromising patients' privacy. Okay, and this takes us to the way forward-looking responsible AI in healthcare. As we move forward, more responsible AI deployment in healthcare is essential to focus on building safer and more transparent AI pipelines. First, we need to ensure regular fairness audit. And that is, like I explained earlier, fairness audit is very important when you're building AI systems for healthcare. Just like clinical systems undergo periodic safety checks, AI systems should be continually audited for bias across patient subgroups. There should be some input modalities and evolving data sets. So fairness is not a one-time fix. It is an ongoing process that we all need to work on. And the second thing to talk about here is that we can implement debiasing strategies such as adversary debiasing. Advancing debiasing actually is where the model learns to make accurate predictions while minimizing its ability to infer sensitive attributes. And another one is reweighing. Reweighing is when you're building a model as an AI, you can actually reweigh the parameters or add different weights to the parameters, possibly when you are doing hyperparameter tuning. So reweighing is more like what balances underrepresented samples during training. Like if there are underrepresented features, you can actually add some weight to be able to balance it. Another one is what we call fairness-aware loss function. That is what directly penalizes bias outcomes. The third thing is the issue of interpretability when building models. Interpretability remains a cornerstone of responsible healthcare AI. And that is to say that technologies like LIME is what we call local interpretable model agnostic explanation. It is it's a tool used to create interpretability of your model to show how the model's decision was made. We also have what we call SHAP, S-H-A-P. SHAP is sharply additive explanation. And the third one is saliency map. These are all the tools that you can use to create interpretability of your model to be able to make the model show how it came about its decision. And this can help clinicians or doctors or practitioners to understand why a model makes a particular decision. And that can also build trust if they understand how the model makes its decision. So together, these strategies from auditing, the biasing and interpretability can form a continuous pipeline for trustworthy, fair, and transparent AI in healthcare, which can help us in ensuring that predictions are not only accurate, but equitable and explainable at the same time. Okay, so the vision, as we close, I want to also bring to the focus back to the broader vision guiding this entire work. Fairness in health care AI is not just a technical goal. It represents equity, trust, and responsibility. Equity ensures that AI benefits are shared across all patients' population or all groups, as the case may be. And the issue of trust ensures that clinicians and patients can rely on AI-driven insights. And responsibility ensures that we as researchers and practitioners can remain accountable for how these systems impact real lives. So my contribution to this space centers on developing a practical, scalable tools that make fairer achieve, like I say, practical scalable tools that make fairness achievable and in every day AI workflows. Things like fairness audit, proxy based evaluation, mitigation strategies, and geometric of spectral analysis techniques that actually can scale across data types and domains. So the ultimate vision is to build an AI system that not only perform well, but also treat every patient group with fairness and respect, a foundation for trustworthy and responsible healthcare innovation. Okay, so that being said, I will wrap up by taking a moment to thank my collaborators and my research partners from Canada, Nigeria, and across our global team, both in the global south and in the global north, whose contribution and shared commitment to responsible AI, have made this work possible. I'd also like to thank our lab, the Responsible and Applied Machine Learning Lab at Brock University, which serves as the core of this research, bringing together students and collaborators working on fairness, interpretability, and responsible AI in healthcare and beyond. You can find more details on our ongoing project and publications on our lab. Then you can also reach out directly, via my email or any social media handle that you want to reach out to me. Let's talk about fairness. Let's make sure that the AI in healthcare reaches everyone and is also shared equitably. Thank you for your time and engagement. I look forward to your questions.
Thank you so much, Professor Blessing, for this very detailed presentation on this very, very important topic. Are there any questions? If you have a question, please indicate by a raise of your hand and we will take your question. Is there anyone with a question? You can also drop your question in the chat. While we wait for that, Professor Blessing, I have a question. I have heard people ask that can AI fairness be truly achieved in the global south? What are your thoughts about that?
All right, thank you very much. That's an interesting question, and that has been a very important discourse over time. Okay, so yes, AI fairness can actually be achieved in the global south, and how it's going to be achieved is by using locally relevant data to build models for the locals. There is what we call federated learning. Federated learning is a kind of approach that we use to build machine learning models where people can build models from their locality. That is to say, I get data from my locals, I use it to build the model, the outcome is what goes out. So the problem we have in the global south right now is that the data that they are using to build models are the data that we are collected from the global north. And that is a problem. Imagine having to build a model where all the chest X-ray data is all white people, or the image data I'm using, or the records I'm using are all white patients. Then, because they keep record, right? Then it becomes a problem because the model will favor the white patient. Whenever the white patient is got, there's a very high chance that it's going to predict accurately for that person's case. But in the issue of the global north, or maybe a Black person from the global south, it becomes a problem because the model cannot properly articulate the features it gets from that person's record. So yes, it can be achieved, especially when we use our locally relevant data to create these models. And as I can tell you, in South Africa, deep learning in Daba is doing a lot, in bringing out young Africans that are actually, developing AI models for Africa.
Thank you so much. We have a few hands up there. I'm going to ask Professor Dennis. You can unmute and ask your question, please.
Yes, thank you so
Professor
much.
Dennis. Yeah.
Yes, thank you so much for this very instructive presentation. It looks so easy, but I'm amazed at just how much you can achieve with simply selecting simple indicators for your proxies. My question is, what's the rationale behind these indicators that you chose? Because you selected things like date of birth, gender, and so on. Is the idea, at least in your thinking, was the idea that because traditional labels are biased, then these subject-specific labels, for example, zip code, you are looking at people in the same area, for example, was your thinking that you find, or at least your model will be able to distinguish, look at those subtle differences between people that share these proxy indicators that you used in your model construction? Thank you.
Oh, yeah. So, thank you very much for your question. So, given the fact that some of these sensitive data, sensitive attributes, like race or gender, first of all, these are the things that amplify bias. Because, if I'm building a model and I don't like a particular person, a particular set of people that has that is from a particular race, or I don't like a particular gender, I can build a model to not favor them. Okay. So, and when we don't have such attributes, or when you are building for fairness, you can actually remove those sensitive attributes and focus on proxy indicators. What we do in this case is try to, use those proxy indicators to try to use them to uncover. We look at the latent subgroup level disparities. In that case, these are things that can remain hidden in the contractive embedding space. This is where we now look at it to check if there is some correlation or some relationship, as the case may be, that can help to make a prediction of that particular classification, or whatever kind of prediction we want to make. So for our case, we looked at these proxy indicators because we can actually infer or get the latent subgroup level disparities amongst them, and we can also use it, get them from the hidden contractive embedding space, because we were working on the embedding data in that sense, not like working on the data directly. We converted them to embeddings. And that was what we used to get some information that was we were able to use to train our model without the demographic or the sensitive attributes, and it worked for us. So yes, I don't know if I answered you. I don't know if I got you.
Largely, yes, largely. Thank you so much.
Okay, thank you.
All right. Thank you so much. We move to Professor Benjamin. Professor Benjamin, please ask your question. Professor Benjamin, can you please unmute and ask your question?
Thank you so much. My question is, how do you think this aspect of AI in terms of fairness, trust, health research could be taken up by government? I mean, in terms of policy uptake, how do you think it could be presented in a way that government of South-South will be able to appropriate this and use it to regulate the use of AI in our different countries? Over.
Yeah, thank you. Thank you very much. This is a very important question. You know, when we talk about responsible AI and fairness in general, that's also the policy part, which I mentioned earlier, where I talked about the EU Act, the TDA, stuff like that. We also have the UNESCO. We have UNESCO, we have the what we call the General Data Protection Agency. We have another one for Canada. So there are policies, government policies. That's why you see that most countries, they have AI strategy, they have AI Act, you know, that function and all this. But just that most of the countries in the global south are not serious. Well, I will not say they are not serious, but they don't take these things seriously. In the global north, okay, first of all, let me say in general, because AI is a very evolving thing, it's so difficult to have one general framework or policy that guides it, because you create one today, boom, tomorrow, you know, AI develops and becomes a different thing altogether. Then it becomes a little bit of challenge. But there are still some policies that everyone follows. So yes, government, a responsible government that pays attention to the AI development can bring stakeholders in the field, experts. When I mean stakeholders, I mean like experts, AI experts, bring health practitioners, bring lawyers. That's why now we have tech lawyers that come together and write a document that can guide the development of AI, what should be done and what should not be done. For you to deploy AI in healthcare, for instance, a medical practitioner, a health person, an AI person, and even a lawyer can come together and say, this is, the doctors will say, this is what we accept in our own field. Then the AI person will now say, this is how we can do it so that it can work well for you. The lawyer can now institutionalize it by writing it in a way that it can become a law. The government can pass it as a policy. So it's an inclusive thing that they can come together, come up with a working document that can guide the development, the deployment, and the use of AI. That a lot of countries are doing. Like I said, there's the EU Act on AI, there's the United Nations Act on AI, there's one Canada is doing, but all these things are, will I say, geopolitical, in the geopolitical context where you have a lot of, you know, they're bringing these policies that can be very general. But now you can borrow a leaf from these general policies and, you know, create a country-specific one that can favor your country, and that should also be revisited, you know, oftentimes, so that it can always you can always update it to be able to accommodate the rapid development of AI. So the way you can do that is for a responsible government to look into AI and know that AI is one thing that we can no longer do without. It's already here with us. As a matter of fact, as I was telling some people that when they say AI is going to take their jobs, AI is not going to take anybody's job. But AI, the people that refuse to embrace AI probably will be left alone, will be left behind, if I may say. So any government that refused to, you know, embrace this and come up with this working document that that should be, you know, updated either every year or every 2 years, should be updated, revisited, and, you know, make sure that it accommodates the rapid development, then probably they will just be behind.
Thank you so much, Professor Blessing, for clarifying that that question. We'll move to another question by Gloria. Gloria, are you there? Please unmute and ask your question. Gloria.
Okay, thank you very much. Yes, sir. Thank you, Professor Blessing, for your lecture. It's really quite enlightening. Thank you so much. The question I really have is that as far as fairness is concerned, using AI in medicine, for example, to make diagnosis or probably to aid in outlining treatments and all of that. To what extent can such apps be trusted? Like, is there a litmus test for you to be sure that whatever you are getting from this AI, is correct and can be trusted? That is number one question. Then number two question is that sometimes you have students or trainees under you that need to write up some work. So in ethics, to what extent, as at now, is there any guideline to what extent should AI be used in the development of such works? Or is it just like you can do whatever you want with AI? I don't know if you get my question.
Yes, I think I got your question. So
Thank you. Thank you so much.
Yeah. So your first question is the issue of trust. So I believe you were here when I started. I talked about trust. Trust is a very big thing in the development of AI, because when people don't understand what you are doing, they will not trust the system. To how extent we can trust it? There is what we call human in the loop when you are developing AI, when you are implementing and when you're using it. That is to say, you don't just give AI something and it gives you an answer and you text it like this. Just like use ChatGPT, for instance, or Gemini, if any of you that use it. You see, when you prompt something to it, you don't just take whatever thing it gives you, hook, line, and sinker. You probably have to read it, and if it doesn't give you the right answer, you ask it again that this is not how I want it, or you try to prompt and fine tune. We say prompting engineering. You can continue to do that until it gives you what you want. You don't just take it like that. Now, bring it back to a sensitive area like healthcare. You don't just take what AI gives you as it is. What happens here? As much as AI is helping us to, make things efficient for us, we still need that human in the loop. We still need that expert knowledge. That's why you still have doctors using these AI systems. However, they also should understand with to know how the AI comes around about its decision. For instance, if you, as maybe a medical person, comes to say you need an AI that can help you to, okay, I'm going to give a simple example. One of my collaborators built a system called Roslyn. Roslyn is an agent-based system that takes patient's record and gives it to the doctor. So that time when a patient comes to the doctor, start telling the doctor, I'm having a headache, I'm feeling this, all those things that you'll be telling to the doctor, and the doctor will be taking note. Because there are shortage of doctors in South Africa, in Canada, he built that system that interfaces that with the doctor in that sense. That what it does is you are logging into it. It converses with the patient, gets all those records and sends it to the doctor, right? The doctor will now read them. When the patient now comes, the doctor already knows what the patient is passing through and can be able to just begin to administer whatever. Now, before that was done, there has been series of testing. There has been series of look at how the doctor will first of all probably give information of look at the kind of questions we ask. And when we ask this kind of questions, look at the kind of answers we expect. If it doesn't go this way, look at what we expect. These are the things that creates the knowledge base or the data for the AI. Now, if all these things are gathered with the doctor in the loop, that is transparency. And when everything happens and the model comes alive, the doctor 100% will trust the model because he was part of it. One of the things we also talk about in AI and healthcare is, the issue of data collection and data as well. People should know what you're doing with their data. That's also what we call the right to be forgotten. Like if you finish building the model and what do you do with the data, you have to, destroy or forget the data and all that. So if people are aware what their data is being used for, the output of it, how the model makes a decision. If the model takes in data, I'm going to give a very layman's example. Let's say I take medical imaging of chest X-rays, right? And I pass it into a convolutional neural network. I tell you that this data is processed into pixels, and these pixels becomes numbers. And when they becomes numbers, there is a pattern these numbers can be. If it is distorted or if these numbers start changing in a very funny way, then I can tell you there's a likelihood that this person has some anomaly in the chest image. And that anomaly could be cancer or could be a lump somewhere. That can be, you can see how that process happens and how the image converts to grayscale, from grayscale to numbers, from numbers to the pattern of the numbers, how they appear. If all of them are appearing in the same format and all of a sudden another one starts changing in a certain way, then there's an anomaly, and that anomaly could be predicted to be either a lump or something. Then at that time, it does not say it's cancer or anything. It will just tell you an anomaly detected. You as a professional, which this is where we now see human in the loop. A doctor can now say, okay, can I see this result? Anomaly detected at which position it shows you. You can now view it and say, oh no, this is cancer or this is not cancer. The AI has actually helped you in dictating, in going far to, helping you to do the work without, you doing a lot, assuming we have a case like that. This is just for argument's sake. So yes, we can trust the system based on the fact that the system is transparent. And the other question about how far we can use this system, or if you give a student something to do, okay, that's what we call AI dictators, right? Like I was telling them where I'm in my school that I am an advocate of the fact that we can tell students to use AI to do whatever they want to do, but we can regulate it. So allow them to use it, then regulate it. How do you regulate it? There are AI detectors. For instance, just like Turnitin, for those of you that understand Turnitin, if you throw in whatever somebody has written into Turnitin, it will give you the plagiarism index. The plagiarism index will tell you, it will match the similarity of what that person typed with every other sources on the internet. If that plagiarism is, you can put a benchmark. If that plagiarism, or if the similarity index is, let's say, more than 10%, then you penalize that person, that the person has cheated or the person, copied, as the case may be. The same way with AI dictators. If you throw in a document into an AI dictator, it will tell you that this was written by AI, by an AI tool. So if you allow students to use any AI, because just like Google, AI now has become very handy that people can easily put in things and get the result. You can tell them you are allowed to use it. However, the similarity index should not be more than 5%, should not be more than 10%, should not be more than 25%, depending on the number of whatever the size of the document. That way, they will know that when they get information, they don't just throw it in, verbatim. They will probably read it and fine tune it to with their own language. If it's something that has to do with a write-up, and so that when you throw it into an AI dictator, you can even tell them, look at the AI dictator I'm using, so that they can also use it to better themselves. That means when they finish writing, they can try it there. The thing will tell them, no, you have a 10% similarity or 20% similarity. So that way, they can use it, but you can control how they use it. I don't know if I answered you. Thank you.
Thank you so
Yes.
much, Professor Blessing. That's really helpful. I'm sure Gloria is happy with the answers. We will check some of the questions in the chat and then see if we still have some. I think we have some. I think some of them have also been answered in the process of responding to the other questions. How can we really trust? I think that has been answered. So the issue of trust has been answered. Um, yeah, if you have any new question, you can drop in the chat. The presenters are ready to answer. Um, I have a question for you, Professor Blessing, while we're waiting for a few more questions. Yeah, you've talked about how different disciplines need to come together to tackle the issue of AI fairness. But in your view, looking at the global south, who do you think should be responsible for auditing AI systems for fairness? Should it be the developers? Should it be the regulators? Should it be the healthcare institutions themselves? Who really should be responsible? Probably that will help inform policy as we work with governments in the global south.
Okay, thank you very much. So I teach a course right now called Responsible AI. It's a graduate level course. And one of the things we talk about there is things like this. After doing that course, you already automatically become an AI auditor because we will equip you with all the right information to ask. So to answer your question, the people that are trained to understand responsible AI are the people that are supposed to be the AI auditors or the people that are supposed to enforce this fairness. However, on the policy side, governments are, they bring experts, like I mentioned earlier, that people that are well-trained, people like us, the AI people, the tech lawyers, and of course, the government, the doctors or clinicians, as the case may be, to come together and write a working document that can serve as a policy document to regulate these things. So when there is a document, anybody can now, enforce it. I don't know if you understand. All you need to do is you have the policy document, you go wherever AI wants to implement, it wants to be implemented. These things, it becomes like a checkbox, right? If all the things are properly aligned, if all the implementation process, the data collection process, the usage process, and all that align with the document that you have, then you can pass it for it to be used in that system. So I would say the main thing is putting up the policy document, which is where I've mentioned is a collaboration, a combination of medical practitioners, AI experts, and tech lawyers coming together to have this document. The document becomes something that will regulate the use and implementation anywhere, and anybody can be the watchdog in that sense.
Thank you so much. I'm checking the chat for any other question before we close. We're coming to the end of this session. If you have any other question, you can raise your hand or write in the chat. But in the absence of that, I really would want to thank our presenters today. They've given us some really, really wonderful presentation. These are two important topics. I'd like to thank Professor Manuel, who spoke earlier on and gave us his insights from the experience in Dominican Republic. We really thank you for coming and for sharing your experience with us. I also want to thank Professor Blessing for this excellent discourse on the issue of AI fairness. This is a really, really critical topic. It's complex, but really vital, and we can't run away from it, as you have heard from him. So the earlier we begin to work with governments to see that these are part of the policy formulation around AI, the better. So I thank all of you once again. I also like to thank everyone in the audience for coming to this meeting. And we look forward to seeing you again at the next lecture series. Thank you, everyone, and bye-bye.
Bye, everyone.